In this section, we'll be discussing both local and general anesthetics. In this section, we'll be discussing anesthetic medications, both local and general. Let's talk briefly about general anesthetics. Most general anesthetics work by enhancing GABA activity, especially the GABA A receptor. Remember that this is an inhibitory neurotransmitter receptor, therefore activation would cause central nervous system depression. In general, when we give general anesthetics, we use multiple medications. And the reason is we would like to avoid prolonged stage 2 of anesthesia. We'd also like to achieve muscle paralysis and pain control. Usually one medication is not enough to obtain all of these goals. It's important to remember the stages of general anesthesia. The first stage is analgesia. Depending on the agent that we give, the amount of pain control can be very little or a lot. Stage 2 of general anesthesia is the phase that we like to avoid. Patients in stage 2 will exhibit excitement, delirium, and combative behavior. So very many times we will give an agent that will take a patient immediately to stage 3. At the same time, we give a medication that works more slowly to reach stage 3, but will last a longer period of time. Stage 3 is considered the optimal place for a patient to be during surgery. This is called surgical anesthesia. These patients are unconscious, but they're still breathing regularly, and they can have decreasing eye movements. Stage 4 is considered medullary depression. These patients can undergo cardiac depression and arrest, as well as respiratory arrest. When a patient is in surgical anesthesia, sometimes then they will be paralyzed by other medications, neuromuscular blockers, in order to perform surgery on these patients. Inhaled anesthetics include both older forms of anesthetics, including nitrous oxide, which is also known as laughing gas. This should not be confused with nitric oxide, which is a cell-signaling molecule. The newer inhaled anesthetics include isoflurane, seroflurane, and desflurane. These are commonly used in the operating room today. Nitrous oxide, as you can see here, has a very simple structure, whereas the other inhaled anesthetics contain more complex structures. You can see that they contain a lot of fluoride molecules, as well as chlorides and bromides. There are some important concepts that we should talk about in general anesthesia. The first of those is the MAC, or the minimum alveolar concentration. The MAC, or the MAC, is a measure of anesthetic potency. Generally, a higher MAC value indicates lower potency. It's important to remember that. This is analogous to the ED50, but is measured as a concentration in the air. MAC is equal to the percent of inspired anesthetic at which 50% of patients do not respond to a surgical stimulus or pain. MAC values are also lowered by administration of other opioid analgesics. This is why oftentimes when we're giving a general anesthetic, we will also give fentanyl, which is an opioid analgesic, which allows less of the general anesthetic to be used in these patients. For nitrous oxide, the MAC is actually greater than or equal to 100%. Therefore, we cannot use MAC very much as a single anesthetic agent in surgical anesthesia. MAC is also inversely proportional to its lipid solubility. As you can see here, nitrous oxide has a MAC of almost 100, whereas the other medications that we commonly give for surgical anesthesia have MACs that are much lower. This is considered to be the percentage of anesthetic gases in the lung alveolus that is able to cause anesthesia. And you can see this is around 1%, meaning these gases are very good at causing anesthesia. Another important concept to remember for general anesthesia is the blood gas partition coefficient. This coefficient is a measure of the solubility of the anesthetic in the bloodstream. And what we mean by this is when the gas is inhaled by the human, it enters the bloodstream. Some of that gas remains a gas in the bloodstream, whereas the rest of it is solubilized in the bloodstream, meaning it's not a gas anymore. The more soluble anesthetics, meaning the anesthetics that are able to enter the bloodstream and become part of the blood, take longer to achieve partial pressure in the brain because they want to stay in the bloodstream. Other anesthetics are happy to leave the bloodstream, and they would have less solubility in the blood. Halothane, of all the inhaled anesthetics, has the most solubility. It has a higher partition coefficient. Therefore, it has a slower onset of action. Desflurane is less soluble in the blood. Therefore, it works very quickly. Because as it enters the brain blood supply, it will leave the blood supply and go directly into the brain, instead of staying in the blood where it's very soluble. Again, the blood gas coefficients are inverse to the ability of the drug to cause anesthesia quickly. Here you see halothane, which is more soluble in blood than isoflurane, desflurane, and enflurane. In order for a patient to recover from general anesthesia, the drug has to leave the brain, go back into the bloodstream. The recovery rate depends on the solubility ratio. Highly soluble anesthetics, again, have a low recovery rate. The newer anesthetics, however, have very low blood gas solubility ratios and can cause very rapid onset and rapid recovery. Let's talk specifically about the inhaled anesthetics. Nitrous oxide is an older medication, has low potency. It's sometimes used for dental procedures. The mechanism of action we're not sure about, and we know that it does not act like the other medications at GABA A receptors. The other medications, desflurane, enflurane, and halothane, which are commonly used, have specific side effects that are commonly seen with each one. For example, desflurane is very irritating to the airway, whereas enflurane is associated with convulsions. Halothane, which is less commonly used today, may cause malignant hyperthermia more than the other inhaled anesthetics, as well as hepatitis. Those are the inhaled general anesthetics. Now let's talk about some intravenous general anesthetics. The most commonly given ones that we see today are thiopental, propofol, and ketamine. Thiopental is very lipid soluble, and it's a barbiturate. Thiopental is very commonly given intravenously for induction of general anesthesia to help the patient go past stage 2 of anesthesia. The way that it works is by depressing cardiac function and respiratory function, and can cause CNS depression as well. It's important to remember that thiopental has redistribution because it's very lipid soluble. It can cause hangover effects that we'll talk about. As thiopental is infused, the concentration will go up in this patient approximately to 50. When it's stopped at this point, the concentration will trickle down quickly and then take a long time to reach 0. And this is the hangover effect, because the drug is leaching out of the fatty tissues at this point into the bloodstream. Propofol is very commonly seen in both operating rooms and in the intensive care unit. It's the best-selling general anesthetic worldwide up until 2002. It's not only used for induction, but sometimes maintenance of general anesthesia. It's commonly used in procedures as well as like oral surgery. Propofol, also known as Diprivan, is very poorly water-soluble. Therefore, it's supplied as a milky solution that contains a lot of lipids. It also, just like thiopental, can cause a redistribution phenomenon. But it has a more rapid onset and recovery phase, and it's widely used for outpatient surgery. Ketamine is another intravenous general anesthetic that is commonly used in children. The way ketamine works is by inhibiting the NMDA receptor. Remember, that's a glutamate receptor. The way that it works is by producing a dissociative anesthesia. These patients can sometimes have their eyes open, and they can still move their muscles, but the drug itself is able to cause analgesia and amnesia. Again, it's used in the pediatric population. It can also be used in remote settings because it's very easy to use. These days, it's become more of a street drug of abuse. It's also known as Special K. It's related to PCP. Adverse effects of ketamine. Again, this medication is known to cause vivid dreams and hallucinations. For this reason, children seem to tolerate the drug better than adults. Let's talk briefly about local anesthetics. The most commonly given local anesthetics include lidocaine, bupivacaine, and procaine. The way these work is by providing regional anesthesia. We're also able to block entire nerves with these medications. These can be injected near the nerve bundles or into the epidural or subarachnoid spaces. Lidocaine, remember, is also used for cardiac arrhythmias because of its sodium blocking potential. The way that these local anesthetics work is by blocking voltage-gated sodium channels. So if this were a neuron's axon, and you were to give lidocaine in this region, and the nerve bundle is transmitting to the right, The lidocaine would block the sodium channels here and prevent transmission of the nerve signal downstream. Therefore, this is how we do nerve blocks. If you plan on doing a surgical procedure in this area, you could block the nerve here and prevent the nerve signaling from going past this point in both directions. It's important to remember that local anesthetics are weak bases. Their pKa's range in the 8 to 9 area. In a physiological pH of 7 or 7.4, about 1 to 10% of the molecules will be non-ionized. In order for these molecules to cross into the nerve membrane and do their job, they have to be non-ionized. However, in infected tissue that has lower pHs of about 5, that number drops from 1 to 10% to 0.1%, making it less easy for that molecule to enter the nerve and to anesthetize the nerve. Let's talk about the pharmacokinetics of local anesthetics. The ester family of the local anesthetics include procaine, cocaine, and benzocaine. These are metabolized by esterases in both the plasma and the tissue. The amide local anesthetics, remember, have an I in the first part of their name. As you can see, lidocaine, bupivacaine, and mepivacaine. And they're metabolized by amidases. The reason that this is important is that butyrylcholinesterase activity can vary from person to person. Therefore, certain patients would be more sensitive or less sensitive to the esters than they would to the amides. You can see here the structures of lidocaine and procaine. This is the amide bond here in the lidocaine molecule. This is the ester bond. Some adverse effects of local anesthetics can include dizziness, nystagmus, sensory impairment, and seizures, especially when the medication, such as lidocaine, is injected into an artery. Therefore, when you're injecting lidocaine or local anesthetics, it's important to pull back on the syringe to make sure that you're not in a vein or an artery before you inject the solution into the body. Most of these local anesthetics can depress cardiovascular parameters except for cocaine. Let's talk about neuromuscular blocking agents. These are medications that are used during surgical anesthesia or stage 3 anesthesia to cause muscle relaxation and immobility. This can be very important in patients that you're performing surgery on so they do not move their muscles. The way these blocking agents work is by interacting with a nicotinic acetylcholine receptor at the neuromuscular junction. And these are classified into two different categories. The first is non-depolarizing and the second is depolarizing. Here's the structure of acetylcholine in the middle. On the top, you see pancuronium, which is related to curare. We'll talk about these later. And succinylcholine. Succinylcholine is related to acetylcholine, therefore it's depolarizing. Pancuronium is not related chemically to acetylcholine, therefore it's non-depolarizing. Let's talk about the non-depolarizing agents first. Remember, these are competitive antagonists to the nicotinic receptors. Their action can be overcome by high concentrations of acetylcholine. The prototype medication is turbocurarine, which is isolated from the skin of a poison arrow frog. The action of these medications can be reversed by cholinesterase inhibitors, which are called reversal agents, such as neostigmine. These agents, again, can cause progressive paralysis. They do not affect cardiac or smooth muscle, and they do not alter consciousness. Therefore, patients that are not under anesthesia should not receive these agents. We'll start with the individual agents. Mivacurium is commonly used in the United States. It has a very short duration of action because it's very quickly degraded by plasma cholinesterase, also known as butyrylcholinesterase. One side effect with this medication is known to cause allergic reactions associated with histamine release. Pancuronium is a steroid-based compound. It has a long duration of action. It's not metabolized by the plasma cholinesterase. This is more commonly used in longer surgeries because of its longer duration of action. Atracurium is usually used in shorter surgeries because it has a rapid recovery time. It's inactivated in the plasma spontaneously. It does have a breakdown product called laudanosine, which is associated with seizure activity. Cis-atracurium is very commonly given in the United States for muscular blockade, especially in the emergency room because it works very quickly. Emergency room doctors just call this CIS. Vecuronium is also very commonly given. It has a very short duration of action. It's a non-depolarizing blocker. Its duration of action is approximately 30 to 40 minutes. It has very few side effects and is very safe. Let's talk about depolarizing neuromuscular blockers. These are actually agonists at the nicotinic receptor. The prototype depolarizing neuromuscular blocker is succinylcholine. As we talked about before, succinylcholine is related to acetylcholine in its structure. The way it works is it causes persistent activation of the nicotinic receptor. When you give succinylcholine to a patient, the first thing you'll see fasciculations in the muscles of the patient. And after that, you'll see flaccid paralysis. It's important to remember that succinylcholine is not reversed by reversal agents. The pharmacokinetics of succinylcholine include a short duration of effect. It is rapidly inactivated by plasma cholinesterases. It's classically known to cause hyperkalemia. Because of the rapid activation of the muscle, it causes potassium release from the muscle into the bloodstream, where it can increase plasma potassium concentration. Succinylcholine is very commonly seen to cause malignant hyperthermia, much more than other medications, especially when given in conjunction with an inhaled anesthetic. As we talked about before, some patients have a butyrylcholinesterase or a pseudocholinesterase deficiency. This is an example of a pharmacogenetic disease. It can affect medications such as succinylcholine and mivacurium, which rely on butyrylcholinesterase for their degradation. In about 1 in 5,000 Caucasians, they can be affected and paralyzed for hours by these medications until these drugs that are given, succinylcholine and mivacurium, are eliminated by other pathways. Let's talk briefly about spasmolytics. These are medications that work by decreasing muscle tone and spasm. They can be very helpful in patients that have developed cerebral palsy or some injury to the spinal cord. Baclofen works by agonizing the GABA B receptor. It will activate that receptor, which is an inhibitory receptor, which causes hyperpolarization of neurons as well as muscle downstream of those neurons. The way that it works is by increasing potassium permeability. And the way that works is by increasing the positive charge outside the cell compared to the inside of the cell, which causes hyperpolarization and inhibition of that neuron. Dantrolene is a very important medication to remember for step 1 as well as your careers. The way dantrolene works is it blocks calcium release inside a muscle cell from the sarcoplasmic reticulum. What this does is it decreases the likelihood that the muscle will contract. This is known as the antidote for malignant hyperthermia, a common condition that's seen in patients that are receiving anesthesia or neuromuscular blocking agents such as succinylcholine and halothane. Again, this is a rare adverse effect seen in combination with multiple medications. These patients exhibit extreme muscle rigidity and hyperthermia. They need to be cooled quickly and they need to receive dantrolene. Most operating rooms have a cart specifically for malignant hyperthermia that can be wheeled in that contains ice packing as well as dantrolene. This concludes our section on anesthetic medications. Our next section will involve opioid medications.